Welcome. It is my pleasure to introduce our panel to our audience, which we cannot see, but I hope you can see us. And we are going to discuss anemia management, have an update on a meeting that we had here in Vienna. It's an international forum on blood transfusion and ESAs. We will start with an update on EPO receptors and tumor progression. And I will give the word to Pere Gascon from Spain, who will discuss this problem for you now.
Okay. All right. Hello, everybody there. This morning, we discussed the EPO receptors and tumor progression. You can see the slide. And we have three pertinent questions, open questions. Well, this is my disclosures. Are there EPO receptors on tumor cells? Is the EPO receptor in tumor cells functional? In case it is. And can ESAs stimulate EPO receptor in tumor cells in vivo? We addressed this issue this morning, and we just pick up relevant slides. We pick up this slide, among others that we discussed this morning, for the following reasons. This is a follow-up of the famous paper of the enhanced study by Dr. Henke that was the first alarm signal, in fact, on ESAs in cancer. And you can see here in the graphics that the study was negative against ESAs, and then he got many samples, biopsies, from those that the study, and show that those cells that have EPO receptor, okay, you can see in the panel, okay, in red is the EPO did worse if they have EPO receptor in the membrane. And they didn't do nothing if they had negative. In other words, the present EPO receptor, the authors claim there was a proof, number one, the EPO receptor is the membrane of tumor cells, and second, the poor outcome. As you're going to see in the next slide, this is not probably correct because they were using a polyclonal antibody, poor specific. Next slide. The authors prove that most likely what they are binding with the polyclonal antibody is the heat shock protein. Heat shock protein 70 is a protein that is expressed in cells that are really under stress. They are in the hypoxic conditions and with low pH, and also carries a poor prognosis for the patient who has those cells expressing heat shock protein. So the authors are going to be very briefly. They show a band, which is not the EPO receptor band, but because they already have the feeling, the suspicion that polyclonal was binding heat shock protein, before repeating that gel, they mix the heat shock protein 70 with the polyclonal. If the polyclonal will recognize the heat shock protein, then we'll see no band. And exactly what happened. See, the band disappears because that polyclonal antibody recognizes heat shock protein. So that is a very important issue because all the data has been done till now on EPO receptors have been used a polyclonal antibody. Next slide is very important because Swift, Elliott, McKay, and authors from Thousand Oaks, they developed cell monoclonal antibodies against EPO receptor. And this is a paper published in Blood where they get around 60 cell lines, human cell lines. They check for EPO receptor, and with a monoclonal antibody specific for EPO receptor, they found no binding whatsoever. Then they exposed those cells to EPO, high levels of EPO. They found no single transduction, really abnormality. So the authors now say that at least in these 60 cell lines from human tumors, there's no EPO receptor in the membrane, and they're not functional. We have to wait now for the same authors have data in an abstract fashion where they check human biopsies from 220 specimens, and in the abstract form presented in ASCO 2 years ago, they see no whatsoever presence of EPO receptors in human fresh tissue. We have to wait for these results to be confirmatory of what they already published in Cell Lines. All right, now, this is for EPO receptors. Now I'm going to go, other part of my discussion was, what about safety? What about tumor progression when we've ESAs? Something that as clinicians, it bothers us a lot. So we pick up 7 studies done over the last 2 years. Interestingly, among these 3 studies, there are 3 that touches patients on adjuvant or neoadjuvant treatments. Very important because the regulation said we should not, basically they advise us not to use in the adjuvant neoadjuvant setting. But well, 3 of these papers are on these patient characteristics. So we just pick up a few for the sake of time. Obviously, the first one, which is very relevant, I think the Heinz Ludwig published in 2009 in JCO, where he got six studies on darbepoetin alpha and saw the safety of those studies. The total amount of patients, around 1,800 patients, so it's a big, for the 6 studies you put all together, is more than 1,800 patients. And the bottom line of the study, as you can see, is that the overall survival overlaps the darbepoetin group from the placebo group. Very important, but what is very interesting on this slide is, as you can see, these are follow-up of more than 4.5 years. And during 4.5 years, there's no alarm signal, and the 2 curves, one overlap the other. So it's quite reassurance that probably the new data coming lately, the last year, 2 years, is quite safety from the point of view of ESAs and tumor progression. Then the last one I'm going to show to you is the paper by Dr. Delarue, who also was present in the audience this morning here in Vienna, where the French group, they study diffuse large cell lymphoma and also in a curative setting, and they give darbepoetin arm or no darbepoetin arm, and here the conclusions. You can see that progression-free survival 3 years, okay, 66 in darbepoetin versus 58. Disease-free survival 3 years is also significant. Probably you're going to like more the next slide. The next slide shows in the second interim analysis, okay, the overall survival at least is neutral. So it looks at 10 for a better outcome. The disease-free survival is positive, is significantly in favor of darbepoetin, but the survival, which is our main interest, is neutral. So I think that Mario, with this, ends my intervention at this moment.
Well, thank you, Perry. We will go on with the next presentation on progression of tumor due to iron or transfusion. So here you can see on this slide, cancer develops as a multi-step process secondary to endogenous and or exogenous effects, and oxygen-free radicals are mostly endogenous products. Antioxidants have so far not been very effective in clinical trials, so it makes more sense to try to avoid by doing something about endogenous production. And one can say that iron is one of the players here. It has a very high oxidative potential, and it induces reactive oxygen species. And these then can induce carcinogenesis through DNA damage by inducing mutations in the different anti-oncogenes. Furthermore, in vitro, iron improves cancer cell growth. So if you go through the literature, there is a lot of literature of this. It's mostly observational, and there is a lot of literature in laboratory publications. But there is an interesting paper published recently on large-scale follow-up of patients. This is a study that was in the American Journal of Nephrology, where over 800,000 patients on hemodialysis followed between 1995 and 2005. So these were patients who were treated with erythropoiesis-stimulating agents, and looking at this large number of patients, the cancer-specific mortality did not increase. So this is a very important information for long-term follow-up of patients. Now, regarding transfusions, there is a large amount of publications, mostly in the surgical field. They are associated in cancer surgery with serious adverse outcomes, and it's urgently needed that new treatment concepts are put forward, and that some kind of blood management may be an attractive, for the patient, may be an attractive option. The best probably available data at the present time is incidences of cancer and in the colorectal area, but still I think we need prospective data on this field. So it's now my pleasure to go on with these presentations with Hartmut Link, who will tell us about EORTC guidelines to see what you do in the normal practice.
Okay, thank you, Mario. I just want to focus on one slide. The major goal of the guidelines in Europe, the EORTC guidelines, focus on 2 points. The first is to reduce the number of transfusions in our patients, and the second is to improve quality of life. And just a summary of these guidelines are depicted here. The first point is just, of course, you have to diagnose the anemia, not only to see if the hemoglobin is low, just to analyze the cause of the anemia, and if it's an obvious cause, it should be corrected. And then the patient should be evaluated if he has symptoms of anemia, and if he has symptoms and the hemoglobin is between 8 and 11, then you should consider to use ESAs. And you see here also iron treatment. IV iron might be recommended if there's a functional iron deficiency. And then the treatment should be continued until the hemoglobin target level of just between 11 and 12 grams per deciliter is reached. And when this is accomplished, then the treatment should be individualized just to have the hemoglobin level between 11 and 12. And without minimal amount of treatment. And furthermore, you should also consider in this situation to treat the patients with IV iron if necessary. That's just the summary of the recommendations.
Well, thank you very much. You want to give me So now we have some time for a discussion with the panel. I would like to ask a few questions. For instance, what is the present day way of managing patients in Russia, Dr. Rukavitsky?
Thank you very much, Mario. I have a direct question: how do we manage our patients in 2012? Speaking frankly, we don't have any revolution or maybe great achievements in the field of anemia now. We collect data, and this is a very important process. But I would like to share with you one of my things as a result of this event. First of all, we don't have reliable data about negative action of ESA to the tumor process. And I suppose we can administrate the ESA in patients with tumors without any doubt now, in this period of time. That's my opinion. Second issue about MDS. This is very, very controversial issue because they have to administrate the drugs, our drugs ESA, out of label. If we administrate these drugs out of label, we must know that they have responsibility of the doctor to the result of this treatment. And we know the patient with MDS, this is the old age group, and they can die. If they die, they can have a very unpleasant situation with lower organs in our country. This is real. This is real. And they must be very careful. And the last point, very important from my point of view, this is the iron and the tumor progression. We have here the wonderful presentation, Mario and Heinz Ludwig, partly. And I suppose that we have to administrate iron in patients with cancer very carefully, very, very carefully. This is my opinion. Thank you.
Well, thank you for your comments. I think the iron issue will be discussed with the nephrology part, which is the second part of this meeting. Do you have in your country any problems secondary to transfusion? Because we have seen that there are a lot of signals in transfusion that point to the fact that there might be cancer problems in transfused patients.
Yes, naturally, we have these problems, the same problems. But if we have ESA and if we have indications for application of ESA, we must do it. We must do it.
So regard MDS, I would like to ask Sophie Park to make a few comments, especially regarding quality of life and impact of disease and so on.
Okay. So we discussed with Valeria Santini and Esther Olivia this morning on the MDS issues with the use of ESA. So first of all, I would like to stress on the fact that ESA does not increase AML progression in low-risk MDS patients. You have two studies demonstrating that, two retrospective studies and one prospective study. Two retrospective studies from the GFM and from the Swedish team, which did not show any increase of AML progression, and a prospective study from the USA with Peter Greenberg, who did not show neither AML progression. And then we have two retrospective studies which showed that ESA may improve overall survival in low-risk MDS patients compared to patients receiving best supportive care. So ESA has utility in MDS use, but we are in a weird position where MDS patients can receive ESA in off-label use in Italy and in France, but you have some recommendations, national recommendations, permitting to use the ESA in MDS patients. The second message is that you have some predictive factors of response to ESA, for example, serum EPO level, hemoglobin level, type of MDS patients like RA and RAS, and the low burden of red blood cell transfusions. So there are still traditional clinical predictive factors of response. And now in the MDS community, we are working on biological predictive factors of response like flow cytometry, gene array, and studies on phosphorylation of EPO signal transduction like phospho-ERK and phosphostat. And the final message is that on quality of life, clearly improving anemia with ESA or with blood cell transfusion improves the quality of life, but you have new tools which could be useful, taking into account the transportation of patients in the hospital, and taking account that some patients have a poor quality of life at the beginning and are improved at the end, and some patients did not improve, so you have to stratify studies on the baseline quality of life in these patients.
Well, thank you for these comments. One question came up in the discussion before, and I don't know if anybody knows the answer, but it would be nice to hear what you have to say. At the present time, a third of the Western European population gets cancer in a lifetime. And MDS is increasing. There are Delphi studies that show that it's increasing with age in the population, just the prevalence. So you will have a third of your patients who will have another cancer. How will be your attitude, and maybe Hartmut can also make a comment on that, how will be your attitude regarding guidelines for ESAs and treatment of patients with an myelodysplastic syndrome and another cancer, not a cancer related to MDS or treatment?
Yes, it is the question that Valeria Santini asked. I don't know. we have just raised this question because yes, these patients are old and they have a lot of, they could have cancer, but it is you too who could answer perhaps to this question.
Hartmut, you comment?
Yes. So I would say I'm convinced that the tumors don't have EPO receptors, so I wouldn't be reluctant to give EPOs in those patients. And so I would think ESAs can be used for patients with MDS and their cancer. Of course, we should not increase the hemoglobin level above 12 and monitor the patients for thrombosis, because that's the major risk I see for ESAs, and other risks I don't see.
So that's a typical example where guidelines are guidelines and you want at the same time to treat personalized treatments for patients, which can be contradictory. So you use common sense. It makes sense. I think we want to take advantage to the fact that in the room here we have Professor Fandry, and one of the questions that came up is the EPO receptor signaling on tumor cells? Joachim.
Yes, thank you. I think so far the evidence is not clear, even from in vitro studies. We have still the major problem, as Per just mentioned, that there's no valid antibody to detect the protein. So we start with our deficits already at the beginning of the signaling. So it's not clear whether this the protein is expressed. If you detect the RNA by a highly sensitive PCR method, that doesn't mean anything for signaling. And the other issue is that some studies have shown that some of the signaling proteins are phosphorylated. However, in these studies, the ultimate goal of signaling, which is the growth of cells, proliferation, could not be shown. So far I believe there is no clear evidence that the signaling cascade works in tumor cells, and in particular at concentrations that could ever be achieved in vivo.
Thank you for the comment. At the present time, guidelines in solid tumors talk about non-curative treatments when ESAs are indicated. So can we have a comment on other situations?
Yeah, well, I would like to ask a question to another, to Dr. Javier de Castro. Javier, it's clear the position of the FDA and the ASCO that says that we should not use ESAs with patients under curative intent. Now, this morning we discussed 7 studies, okay, where 3 of these 3 studies were neoadjuvant, even adjuvant, curative intent. The 7 studies show that all are either neutral or a PFS, maybe even better for the ESAs. How do you think the clinicians will react to this new data, okay? And maybe we can make some impact on the new guidelines.
Yes, for me these results are very important, very relevant. Why? Because these data are supporting our reinsurance the use of ESAs in neoadjuvant and adjuvant setting. And because this data also decrease the fear that medical oncological community has had to use ESAs in curative intent. So I would like to suggest to include this data in new update of the clinical guidelines.
It's quite reassuring, this data, yeah.
Well, Dr. Link is one of the guidelines writers. What is your comment on this?
I think I would extend the discussion with the patients that the alternative is the blood transfusion. And if I explain the problems of blood transfusions, I think for the patients it's easier to decide not to get blood transfusions and prefer the ESAs. Of course, we have to advise the patients that the current guidelines are, let's say, behind the knowledge. They are 2 years old or 3 years old now, and we have new insights in how to use ESAs and so on. I think this I have to discuss with my patient.
I would like to stress that all guidelines, not only in ESAs, they leave a door open for the common sense and for the relationship between the patient and the doctor. So it's not cast in iron.
Yes.
So I think this closes the first part of this transmission of this meeting. The second part will be on nephrology. I just would like to tell you that the first as well as the second part of this meeting is supported by Janssen Pharmaceutical, which is a branch of Johnson & Johnson, but the views on the slides and everything you heard is purely of the responsibility of the faculty members and does not necessarily reflect the views of Johnson & Johnson. This means also that, as you heard now, just the last comments, that you can have comments regarding off-label use of drugs. So thank you, and we go on with the second part of the meeting.